co-convener AIIMS in Haryana, and I would like to welcome you all to the mental health awareness session today. The webinar is dedicated to a detailed discussion by Dr. Nimesh Desai. Welcome, sir, a senior psychiatrist, former director of Institute of Human Behavior and Allied Sciences, and the president of Mano Visak Charitable Society. He has been awarded the prestigious Humphrey Fulbright Fellowship at Johns Hopkins University School of Public Health. We are honored to have you here, sir.
Good evening. Let me first appreciate really how you young students are actually getting involved in a whole lot of awareness activities, including mental health. That's a bit of my bias. But having, as was said, having done clinical psychiatry and mental health as well as public health training and some work, I will kind of try and share with all of you perspectives that overlap between mental health and public health. Okay, let's first begin with this. That's, I hope you can all see these slides. That's the status of our society. And as medical doctors, as healthcare professionals, as any profession, but certainly in healthcare and in areas like psychiatry and mental health, much more, you'll have to really be aware of how you really need to be sensitive to both. Let's pause for a minute and think. All of you, I guess, during the pandemic were entering medical college or had just entered, and then you got on to online classes like you're doing this discussion. But while there were a lot of negative effects, one must realize that there have been a few positive spin-off benefits. Pardon the error there. One, recognition and acceptance of mental health as clinical issues. Two, if you pause and think and realize, a lot of openness about psychological issues and how are you feeling or how am I feeling or how is everyone doing emotionally. Third, most importantly, was importance of behavior for health, individual and community. And you might remember or you might have read about a lot of predictions about there's going to be a psychiatric epidemic following the corona epidemic. Has there been really? No. I'm going to cover that. I hope you'll get that sense from the next few slides, which are essentially just a basis for discussion. There was obviously a lot of tension, universal distress. I do say on a lot of platforms that there is any human being who lived through 2021, 22, and claims or report that he or she did not have psychological symptoms or anxiety or tension at some point of time for one or the other reason, he or she is lying. I mean, that's impossible, having lived through that period, all of us. But I want to highlight for some of you, most of you who will be interested in the larger perspective beyond clinical medicine and clinical practice. Can I just make sure I can see the slide myself? In any case. So first is the clinical psychiatry or clinical mental health at best, diagnosis and management of mental health disorders. The next level, if you realize, is a much larger issue of identification and appropriate services for people with mental health distress. Not everyone with psychological symptoms, some dysfunction or distress will qualify for a mental disorder. And that differentiation is actually becoming very critical to make in concept, in actual practice, medicine or public health. And of course, the larger goal of many endeavors, including the government and the society, promotion of mental well-being, must also tell you that this framework of 3 levels of mental health service needs that some of us have been talking about some years is actually now a part of the National Mental Health Program of the Government of India. And so that's actually very valid. The difficulty is that when you talk about the third issue of mental well-being, I can't but share this with you because all of medical training, even till date, and 20 or 40 years ago, it was much more true, did not and does not, by its very basic paradigm, a framework, does not talk about health, talks about diseases, illnesses. So, medicine in general, public health a little more advantageously placed, talks about diseases, disorders, treatment of the pathology, not of health or positive mental health. And that's a limitation that I'd really like all of us to start becoming aware of in larger context and certainly in the context of mental health. But let's go back in time for the science basis for the issues of mental health before the pandemic of 2020. Uh, it was in 1990s and definitely by 2000 that the paradigm shifted from in health management, health policy, public health, and to some extent clinical medicine and hospitals. Mortality statistics also got added to by concerns about morbidity issues, impact on health and well-being of NCDs, non-communicable diseases during life course, various stages. The concept of, I suppose, some of you, most of you might be familiar, World Bank WHO project beginning in 1990s to continuing now to petering out. Global burden of disease, how do you measure the burden of disease conditions for human race? And not to confuse disability as used here with the other social construct of disability. Disability adjusted life years. That if somebody had long-term diabetes, somebody had long-term rheumatoid arthritis or schizophrenia, he or she and the family also went through a whole lot of burden, and that got calculated as DALIs. So the initial few reports of the World Bank WHO project and around the year 2000 more concretely came to have a recognition in policy, in the society, in science about chronic disability conditions, including mental health, and said that was a huge paradigm shift. There's, of course, a lot of emerging data on comorbidity within physical health conditions and physical and mental health. Don't also forget, just for completion's sake, and so that you kind of have a larger picture in your mind, that for India and South Asia, large parts of Afro-Asia, there's actually a dual burden of disease. The European and the American continent, except for South Latin America, mostly the developed world had dealt with the communicable diseases, large part, effectively, not just treatment, prevention. And then their attention shifted through these projects and other developments to NCDs. We out here had to actually continue to and still continue to battle and work for both. These are some of the important documents. If at all some of you are interested in getting into preventive social medicine, community health, or public health in your career, the 1993 first report of the World Bank, World Health Report 1999, I'm going to show you some minimal data from that 1999 World Health Report. And of course, around the time that I got formally trained in public health was this American Journal of Public Health issue that brought it out very well in lead articles. One, mind matters. Two, is the world behaving badly? The issues of from health to mental health to larger issues of behavior. That's the data set that I wanted to bring to your notice, and I hope all of you can see that. You see, in your medical college or schools right now, or whatever experience you have had, you'll generally have, and this is not about piece of the pie or competition, please be sure, but this is about science as it evolved 25 years ago and it's continued to evolve. The GBT data in the 99 World Health Report said very clearly that there are three major conditions that actually take on 1/4 of the global burden. And you will see cancer centers, you'll see cardiology centers. No, you will not see very big neuro centers or mental health centers. What the 99 report very definitively shifted the whole poll to was that while cancers cause 5% of the global burden of disease, cardiovascular diseases cause 10%, the neuropsychiatric brain and mind conditions actually cause 9%. Three of them put together coming to 24%. For us, whole lot of people in clinical medicine related to public health work, policy, and management, this was big. And of course, don't forget to look at the 16% of injuries related, self-inflicted or others, road traffic accidents, social violence, domestic violence, and all of that. So if you put them all together, and cardiovascular, you will appreciate very easily, and cancers, most of them being tobacco related, lung or oral cancers. So nearly most of this together, 40% of the global burden of disease was essentially mental health or human behavior related. And that brought a World Health Report 2001 focusing entirely on mental health. for the first time globally saying you need a public health approach to mental health beyond psychiatry and Freudian analysis and therapy and one doctor treating one patient. You know, uh, some very crucial minimal data, please, if some of you are aware of. What's the prevalence of mental health disorders? That World Health Report in 2001 brought to 25%, and that kind of seems to hold nearly 25 years later now. Fortunately, India has much lesser rate, about half of that or less than half, 10 to 12%. Also flag in your mind that unfortunately, like globally, there is mental health service gap. There is, of course, a large treatment gap. So if you pause and think, out of every 100 persons in India, 10 or 12% population might have identifiable worthy of treatment mental health disorders, but only 2 of them reach any mental health service. 8 do not. And please flag this because I'm going to come back to this in a minute when we talk about psychiatric epidemic following the corona epidemic. USA, believe you me, has rates of nearly 50% and their own NIH very robust epidemiological studies. I believe, and I have said this in many places, that what they are doing for the world, unfortunately, as a bad example, is over psychiatricizing, over diagnosing, over treating any small day-to-day issue. And we'll possibly pick that up in the discussion today or tomorrow. But what all of these developments and data brought out was that amongst the mental health problem, depression actually was a public health priority as one tangible condition. And way back in 2000, it was predicted by the year 2020, it will possibly be in the top 2 or 3 public health priorities by GBD data. Lo and behold, by 2018, much before the epidemic, and certainly by the time the epidemic happened, it was already top ranking. And so, as I often begin this slide with professional colleagues like you or general public, look at 3 friends of you or 3 people sitting around you. And if they seem normal, 1 in 4, the global data. But let's look at why is depression a major public health priority? One, it's the largest contributor to health burden, as we discussed briefly just now. Major complication is suicide behavior, attempted or completed suicide attempt with behavior. Many other effects, including immunosuppression and immunocompromise. And the most important part of the late 20th century, by the turn of the century, now very well established, is that depression is an easily identifiable, treatable, low-cost treatment condition. And so a whole lot of burden as well as suicide kind of behavior can be actually prevented. In a lighter vein again, somebody looked at it this way. One important thing I want to bring to your notice is this, and I won't name the media house or the magazine, but a very reputed media house with 50 years of, nearly 50 years of huge reputation in print media and a very good reputation by now on television channels. Actually, a few years ago, brought out a lead article saying India is the, they didn't even ask the question. Okay, I'm raising the question here. They were categorical. India is the most depressed country in the world. And as a psychiatrist, as a public health professional, as a concerned citizen, I've been very troubled about this. Please consider, you cannot go by numbers of affected persons because at that time we were second largest in the world population. Now we are the top. We are beating China. And of course, you don't get reliable data from China. And so if you look at absolute numbers, it will appear so. It'll be very easy but fallacious and worse to say India is the most depressed country in the world. You need to realize, and I'm sure most of you realize by now, but please spread this word around as much as you can. Look at prevalence rates as percentages, ratios. What is in epidemiological terms called population estimates. A city like Delhi or a state like Haryana or a country like India, how many persons with depression do you need to plan services for? Yes, that's useful. But population estimates cannot lead to inferences about the ratios or the percentage prevalence rates. It may be, as people have argued, this kind of sensationalizing negative portrayal can be very useful, people argue, for advocacy or reducing the stigma. But I don't think so about stigma reduction. In fact, I'm really concerned about in general population and for young, sensitive medical students populations like we are addressing today and talking with, the negative impact. Please consider this. A young medical student undergoing trouble or possibly some signs of depression sitting in the hostel, or anybody for that matter in the society, on the brink of depression, when he or she reads such media portrayal, that for sure doesn't have good impact. Neither helps help seeking, nor does it reduce the sense of distress or syndromal depression. And so, for God's sake, in the field of mental health or in general, and this is not just here, unfortunately, not just media houses, but some of the most senior experts in various fields are very happy to get onto national and international platforms and declare India is the diabetes capital of the world. It's not. It's don't go by numbers, it's about prevalence rates. Let's come to specifically the issue that I'm sure is a matter of concern in some of you and all of your other friends: depression and suicide behavior in medical students or even resident doctors. Again, during the epidemic, you saw enough, I'm sure, at whatever level you were in the hostel or at home or entered medical college or waiting to do so. There were a lot of reports with concern and with a whole lot of more than concern about doing something. I really want to bring to you a balanced opinion that whilst depression and suicide behavior in medical students and resident doctors is a significant problem requiring due attention at too many levels, please understand, again, if you go by prevalence rates, we need to be real about this. It's not a huge cause for alarm. Yes, every case of depression should be treated. Every possible suicide behavior must be prevented and can be prevented in theory. Suicide attempt, completed suicide, all of that spectrum. But please, let's be more scientific, realistic, and rational about this than get carried away, because it doesn't help anyone. And of course, like I've said, there are far too many factors why this happens. If at all we take it up in the discussion today or tomorrow. And of course, barriers to help seeking. Doctors' own mental set, how the society looks at how doctors should be and expect them to be superhuman, not allowing doctors or young medical students or resident doctors under tremendous work pressure and stress otherwise to be able to feel free to express distress or sense of depression. Those aspects definitely need to be worked on. But again, like we spoke about, depression being portrayed as the India being the most depressed country, there's a whole lot of problems in this area too. What we need is more empathy at all levels, as complete a level of social and organizational empathy as we can for those who are in need of treatment. But please recognize again, there's a range of service needs. There are some medical students, resident doctors who might just need help with themselves, stress management, better life skills management, and be done with it. Or organizational realistic problem solving. Some of them might need counseling. Some of them might need outpatient treatment, a few requiring hospitalization and acute severe treatment. That's the thing that I would like all of us to please understand and recognize. Surely there's a lot of concern in the society, media, governments, National Human Rights Commission that we had a recent meeting on with young doctors and the senior experts. The National Medical Commission, equally. As an example, again, with all respect, there's a recent task force appointed by NMC expected to submit its report by 31st May. We don't have the survey report, I think, as yet, but the media reports are already trickling in that this survey that this task force did, and I'm not entirely clear about the methodology, it was more of self-report, and so it becomes a biased sample and reporting. But media reports, again, with sometimes valid due concerns, sometimes sensationalizing, that this task force found 37,000 students with mental health problems, self-report. Now, sure, each one of those 37,000 or anyone else in need of help must get help, and appropriately with sensitivity, empathy. But please consider this, as I asked Navya to help me out yesterday. The denominator, approximately the number of medical students in this country at any point of time is 5 lakh. So talk about the rate, 37,000, or even if it's say 57 or 70,000, God forbid, or more, out of 5 lakh. So as a repetitive issue. There is time for concern and due action, but not for undue alarm, not sensationalizing. हवा मचाने की जरूरत नहीं है. हवा हवा करने से अक्सर हेल्प नहीं होती है, बल्कि और नुकसान होता है. And it creates a negative induction cycle, I believe. So let's briefly recap. Other than that, and we'll possibly pick this up in the discussion today or the whole long hour or more that we have tomorrow. Depression and suicide behavior, other self-harming and high-risk behaviors. Please remember, the onset of major mental disorders, schizophrenia, bipolar disorder, is in adolescence between 16 to 18 or 16 to 21. And so that also needs to be seen and differentiated from. Adolescent adjustment crisis or disorders, relationship problems. I mean, I'm sure we could spend 10 or 100 hours discussing that and how that can be helped. Alcohol, tobacco, drug use issues. Is cannabis a drug? Should cannabis be considered non-drug? And the full range of sexuality issues. My simplest model for general population and young people has been this. A pressure cooker has two mechanisms. One, to let the steam off constantly, in those small bits. And two, even with that mechanism, there's another mechanism that's kind of safety valve, the second safety mechanism. If the pressure builds up too much, there is a whistle there. Let's all understand for ourselves and be able to spread the word as much as we can of the need to have constant expression, sharing, outlet, ventilation, call it what you want. Do it the way you want. Do it the way it helps a certain person. But that constant release mechanism and the alerting mechanism of that whistle. It's too simplistic, but I do find it very useful to get across to a whole lot of people, including all of us, including oneself. But the other side of it, in a lighter vein, for those of you who care to see it well, please, is this. A pressure cooker also continues to whistle whatever be the situation. So like I'm very fond of saying, and there's respect to people around, and ladies especially, keep whistling even if your ass is on fire. And that's what we need to try and start achieving and helping people do. And I'm going to stop there. I hope I haven't taken too much time. My intention was to only stimulate a few issues as well as share some concerns that I have about how overly sensationalizing it doesn't help, actually harms. But really, we are at, nice. We are only at 5:30 now, yeah? So we have lots of time today from you and other friends who are here, and of course to continue tomorrow. I'll only request this, as many of you as you can, if your bandwidth permits, if not right away, all of you, but at least those who want to join discussions, raise questions, or contribute opinions, please switch your camera on, because that's really then more comfortable and nice interaction, right?
Yes, sir, we'll keep that in mind for tomorrow's session. Thank you so much for today's intriguing and interesting session. And I would also like to thank you for your valuable time and efforts to address such sensitive subject at length and with so much detail. Also, for everyone, we have a panel discussion tomorrow on mental health of medical students and doctors, problems and solutions. We'll be continuing with Dr. Nimesh tomorrow as well.
Akshat Mittal has a question. If I may read that out in the chat, Davya. Sir, how to identify a person around us who might be suffering from anxiety and depression? Great question. Broadly, in this society and including your settings, I guess the 2 or 3 major criteria by which the suspicion should occur is, most of all, significant or gross change in behavior or from one's own basic self. So in the hostel, in the classroom, and whatever other situation, lab, if you happen to have had some idea, or if you're lucky to have had, if that person is lucky to have had you as a friend earlier too, to the extent possible, try and find out if there's a significant change from what that person used to be, right? Because in research terms, if you look at it, or even for psychiatric assessment or psychological disturbance, the best reference is one's own basic self. Please be sure to recognize that there is no perfect personality, there is no perfect well-being, mental health individual. Okay, we all have our traits in personality, we all have our styles, we all have our characteristics of what we do or what we don't do, like or don't like. And so, if you or I, Akshat, have to judge for each other, it will be very helpful to know the basic self. For example, if an extrovert, gregarious, friendly person begins to suddenly develop, introversion, keeping to his or her room, not interacting, not playing with all of you guys, or the opposite, that's important. If a person who was otherwise cool suddenly shows for a significant period, a few days or 1 or 2 weeks, very high significant irritability or anxiety, that's a problem. Biological function disturbance, sleep or appetite, you yourself find or you find in your friends. Significant disability, missing classes, a whole lot. Most importantly, any indication of suicide behavior. And please let me try and say this here. The knowledge has been for 50, 60 odd years that a person with suicidal thought, ideation even, forget later sequence of actions, generally reaches out for help directly or indirectly and drops hints about being distressed, about experiencing such thoughts, in one or the other manner. So being alert to that, I have learned to say this in the epidemic more and more. Sharing is caring. Bilateral. Let's create an atmosphere wherever in microcosms of your hostels or your colleges, wherever larger societies we can. And no societies are imperfect about this, but try and create an atmosphere where each one of us feels comfortable, at least not negative, about sharing distress or sharing one's own difficulties or a tough time or inability to cope. But also let most other people around be receptive to, like you have shown through this question, be able to pick that up and be sensitive to that. And the step two of this, you haven't raised this, but allow me. There is no point giving Upadesh or Gyan. One thumb rule. If you have a friend or a colleague or a classmate who, in your view or by his or her reaching out, is not able to cope, is finding it difficult, please, for God's sake, don't do this fairly spontaneous human thing of saying, hey, everything is all right. Yeah, come on. Pull up your socks and you can do it. I know you can do it. Come on, get going. When a person is going through either syndromal depression or anxiety or any other pre-psychotic experience, or even if it's not disorder, syndromal level and subsyndromal, like we said, the second level, just psychological distress. But certainly when there is a disorder or a disease condition, just doesn't help. One has to understand that that person is trying in all probability and is unable to do so. And so when he or she is unable to do so, merely giving guidance and pushing doesn't help. What are the do's? Offer help, offer a listening ear, and offer and say, if you feel comfortable talking to me, if you feel comfortable talking to somebody else, let me help you just get across to that person, maybe some other friend, maybe a teacher, maybe one of the acquaintances, whoever. Offer a listening ear or at least channelize that. Try not to judge even while the person is sharing. That's one of the commonest other errors. Oh, you have been so good, yeah, you have been so perfect, you're good in everything. How can you become like this? We don't expect this from you. Terribly judgmental. Try and avoid that, please. But I also notice there are other questions. So let me quickly go on. after
Yes,
that?
sir. We are
Right.
more
Uh,
interested.
right. I got
Yes,
carried away by that because that's so important actually. Okay.
sir.
What are the primary factors? Uh, Ishal Ashik, right? What are the primary factors contributing to mental health problems, especially in medical students? To recap, one, in all of us and mental disorders, the level one service need, there is a huge biological genetic component, not of the disease or the disorder, like diabetes, like most others, not all, most others. What we carry in our genome is a vulnerability. Okay. And I'm sure you all get that better than I might have understood ever in life. That vulnerability, when it meets with a certain situation or lifestyle or external factors, that's when the genotype will become a phenotype or be on the verge of expression, right? So biological genetics, certainly for uh, schizophrenia, bipolar disorders, the biological disease of depression, whole lot of those. Anxiety, alcoholism, and drug abuse also with genetic basis. But a whole lot of emotional issues, mild syndrome or anxiety, drug abuse problems, relationship issues might have more to do with the psychological and social factors. Um, and of course, the high stress, the competition, uh, and the whole alienation that most people feel when you join a medical college, you know, uh, is a huge factor. Um, okay, and what do we have there? Then we have how can you treat such person other than counseling? That's Bhavya Sareen. Bhavya Sareen, in fact, I would think that most medical schools by now have one or the other mechanism of, some counselor, mental health professional being available, or the psychiatry department of the medical college, except the circumstance that quite often the medical student doesn't want to go to the psychiatry department of one's own medical college. Again, not very okay, but understandable if people do that. So respect that too, really. But most importantly, I do want to bring up the idea of what most education institutions have found useful: peer counselors. If the college has formally, or if you guys can develop a mechanism of a few people who are inclined, who are interested to get trained just for a few days on basics of counseling. Peer counseling actually is one of the best things for detecting, identifying, and guiding towards proper treatment. Okay. Now, I know this has multiple issues, and I also worked on, besides other academic institutions, on AIIMS Delhi faculty for 10 years, some years ago, 90s. Okay. So I've actually seen that and been through that. A whole lot of this kind of problems is not easy. But to recap, last part of what I was saying, obvious work and NMC's guidelines seem to be that the psychiatry department of every medical school or college will make sure they have services offered to students and resident doctors. Now that's nice. And if that can happen for many cases, yes. But let's also recognize that much as we would like social stigma to be zero, it never is anywhere in the world near zero. And so if there are people who choose not to go to the psychiatry department of where one is working as a resident doctor or even a student or intern, I believe that should be respected. But yes, guide the person to another mental health specialist, maybe in the private sector, maybe another medical college, maybe another institution. Quite often, please recognize again and again, I'll keep saying this, the three levels of care. Quite often, the persons with disorder or syndromal problems will require outpatient treatment. I don't want to say this. Uh, those times are over there where people with mental health problems, syndromal or disorder, would necessarily need admission. By now, let me tell you this briefly again. Most mental health services, at least in India, and biggest mental health institutions like IBAS or NIMHANS or AIIMS, PGI, others, have an admission rate of 1 to 2% only. Okay. So most people who reach a psychiatric service or a mental health service do not require admission. A few might for very specific reasons. But outpatient treatment is easily possible with rest of the life going on as it was. I think we should not lose time, right? What else? Am I missing something, Nave, if you're reading it with me? Sir, how do you figure out when our sadness or anxiety has reached a point that needs professional help? Okay, good question, Smriti. Um, The American tendency of psychiatric professional as well as now WHO seems to kind of do it as per time. Okay. So please remember this. Most international belief systems today would say if you are feeling significantly sad or anxious for more than 2 weeks continuously, then there's a problem. Now that's good as a helpline, but let's qualify that a little further. Especially, and I want to flag this, especially if any one of us has had a real life experience that may be justifiably creating sadness. Loss of a family member, loss of a pet, heartbreak, relationship issues, bad time with supervisor, or some group issues in your class, whatever nature, parental issues, any. Normal grief, normal sadness is also okay and to be recognized with different levels of help. So 2 weeks, one criterion. Two, if you or anyone feels suicidal, that's a red indicator even on the third day. No issues. Like I said earlier, for generic issues, uh, biological function disturbance significant, uh, especially sleep, appetite, libido 2 being the third biological function. If there is significant impairment or dysfunction in executing day-to-day life, at least for a few days or longer, right? Um, never, okay, I'm going to be careful. I was going to say never worry about seeking help early or even prematurely, but I'm qualifying that I'm being careful because the tendency, as I have hinted earlier, if most of you got it, the tendency of professionals at whatever level, counselors, or other medical, non-medical mental health colleagues, and even psychiatrists, I dare say, would be to say you must encourage, you must reach early, and then we'll easily diagnose and start treating. I want to caution against that. A whole lot of problems should not require high professional help or certainly medicines. So, if one has trust in mental health teams and mental health professionals or yourself, to say, I will recognize the level of impairment, level of need, and level of treatment. Let me put it differently for all issues, but certainly depression, anxiety kind of day-to-day experience for all of us, any stage of life, certainly adolescence and this stressful period that 10 years or so, 10 or 12 years that we all go through. There are four levels of help that I've always talked about. One, self-help. If you can help yourself, wonderful. Level two, family and friends, hostel mates, classmates. Level three, like I was saying, if there are peer counselors, if there is counseling service, level four is the professional mental health. So those are the grades through which you work. But yes, for depression, for any nature of suicidal thought and ideation, the basic principle would still hold to err on the side of safety. Talk to a friend, go seek counseling. Of course, be careful of what is my individual concern. Be sure. A whole lot of science and a lot of my colleagues today in India may not agree, but I hope you have got it today or we'll pick it up tomorrow. Uh, there is this huge danger of over psychiatricizing and over medicating or over diagnosing, and we also don't want to do that. Allow me to express this briefly again. We might pick this up tomorrow. But in nearly 40 years of now, mental health institutions like NIMHANS, medical colleges like AIIMS, and now in private sector, I believe really that one of the nicest things that a psychiatrist can do is wherever I was or I am, if you were to come to me, I would understand your problem, assess it at the correct level, and after due assessment, be able to say where appropriate and say, look, Samiti, you're fine. Go home. Don't worry about it. Go home, look after yourself. I'm here if you need, but I will not diagnose or medicate you prematurely or not duty. If you require diagnosis and treatment, I will offer that to you and convince you. If you all know what I mean. I hope you got that point. Hmm? Okay, there is this long one, Hartika Mudgil. Sir, as a medical student who is not as disciplined as a robot, I think I can say about 90 of times I'm in some constant distress, sometimes attendance, anything else. True. Um, how can I build my own mental health? That is Hardika. Adhika, I hope you got at least the starting point of the answer to your question in what I had said on the slides also, and I've said after that. For all of us, including you as potential consumers or affected persons, please recognize the three levels: disorder, distress, or mental health problem, or are we just looking for well-being? Now that obviously is out. You are saying here, understood that there's almost constant distress. I'll keep saying this again in different ways. If that is uncharacteristic of you, till you joined medical school, you are a very different person. Your ability to deal with distress or stresses or exams was different. Then, yeah, there's at least some mismatch between X person and the system. Self-awareness, self-help, or some amount of counseling or talking to friends can help great deal. But like we said earlier, if there are indicators for, let me put it this way, Harika. Unfortunately, again, I'll keep taking over as you're all superbly intelligent, tuned in, and more. Uh, Human race is moving more and more towards task-oriented efficiency and success as measured in deliverables, right? And medical schools, IITs, some of these high stress institutions with youth competition are actually towards the top of that. And so have this acute crisis much more for individuals and for systems. Do we want efficiency and success at whatever rate, at whatever cost, individually or in group? Or do we want a little more empathy for oneself, people around, your friends, your supervisors? Should there be some leniency about somebody not always delivering assignments? Now, that's a very tough. I mean, you're young, you will realize this, I'm sure, as you grow and become supervisors or other important roles. But try and see it from here, at least as young persons of the society. This is almost a roller coaster ride that human race has got itself onto. Okay, you're part of that. And your generation, I guess, in some ways, it can be said much more. So recognize that, see your potential, evaluate your performance, at least strike your balance between efficiency, deliverables, scoring high marks, vis-a-vis your comfort. You're being at least comfortable, if not in well-being state, not significantly distressed. From your narrative, if I might take the liberty, Hadika, and I will not say more than that here. From your narrative, it seems it might be some justification for seeking active help. In those four levels that I said, merely from good friends, maybe counseling, maybe some amount of recalibration, you know, because ongoing stress can't be a great idea, right? Okay, I think there are far too many more, right? Akshat Mittal, does that genetic base also mean that if the parents have a patients of depression? No, 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 no. No, Akshat. See, most medical disorders, except for few disorders, are polygenic, and of course there is this gene versus environment interaction, right? So even if there is, as you are saying, even if there is strong family history of depression or alcoholism or any such mental problem, I would strongly say don't carry the burden and say, oh, I will have depression, I'll get depression whether I do something or not, whether something bad happens or not. Not necessarily. Uh, don't forget that whole lot of polygenic health conditions actually skip generations and people. Okay. Of course, if you are as sensitive as you are and whoever concerned person is, then one can help by reducing stress that we were talking to Harika just now about, not taking undue risks by correlated behavior of gross sleep deprivation or disturbance of sleep-wake cycle, alcohol use, cannabis use. I mean, I know this might sound like Upadesh or Gyan, but just take this as a neutral idea. As you have raised the issue, if I knew at 16 or 18 or 21 that I have a significant family history of depression or severe mental health problems, would I not, on myself, my own consideration, become careful and sensible enough to avoid increasing that risk by some lifestyle behavior? You know, I might say, please be sure. I am of the firm opinion from my early days to now that it's very easy at 40 or 50 or 60 plus to talk about this and expect responsible decision making about one's own health itself. But that often doesn't happen. We all indulge in risk taking behavior on a regular basis or at some points of time in some periods. But at least be aware, be careful, be conscious about that part. I hope that makes sense. Somewhat we can always, please be sure, pick up issues tomorrow, if not later, but today. Okay, Ashita Yadav here is saying, sir, what do you do when you're already under some guidance of doctors? But that, they miss that. But still you are having a lot of mood swings and anxiety attacks. I guess, Ashita, go back to that doctor and say what you are saying. Consider second opinion. No sensible medical doctor, specialist, including psychiatrist, should ever mind that. Whichever setting, again, medical college, even if the person is a senior faculty, HOD psychiatry, whatever. So review with the concerned clinician, second opinion, sure, and review of whatever is being held. I will say this, if this gives a positive message, I should have said this earlier in the slides. I've been saying this for at least last 15 or 20 years very confidently in all the media's opinions also. By now, 99% of mental health problems are eminently easily treatable. For general population, it says, certainly for us, if we take care. Not cure. And if we flag this, Navya, maybe we'll pick this up tomorrow, the issue of cure versus treatment. If you'll please make note of some issues, yeah. But treatability, yes. There is no reason, at least for 40 years that I spent in psychiatry, 40 plus, at least all through 40, but certainly for last 20 years, I can see why any individual should continue to suffer or the family should continue to feel helpless for control of symptoms and treatability. So, Ashita, time for review. Time for review. Okay, Navya Khanna, our young coordinator, is saying, sir, unfortunately, we have made a normal thing for medicals to have stress and our control to become accustomed to handling stress. Many times we can't draw a line between that normal and what actually is there. Yes, very true. Like I think you and I kind of said, and again, we'll flag this today, maybe for discussion tomorrow. Larger issue. Medical students are obviously, as a rule, terribly successful, intelligent, super successful, well adored in their family and neighborhood and societies, kind of young boys and girls who get into a medical school. The expectations from oneself, the expectations from the family, from friends who are not with you, especially. This expectation becomes a serious problem. And don't let that happen, as Navya is hinting, based on our exchanges in last few days. One thing that doctors need to do and pass that message on to young resident doctors, medical students, is not to let yourself get into the state of being superhuman. None of us is at any stage of life, including one's own health and mental health issues. So to feel stressed, to perform better with minimal or appropriate stress is fine. But Navya, I'd also say this, alongside what you're getting me and prompting me to say appropriately, is also there be no shame in seeking help. Now that's a bit of a delicate balance. Learn to deal with day-to-day stress and whatever problems the career that you have chosen brings, and it's never easy for most people many times. But also, like I told, I think one of the colleagues earlier, no sense of shame or hesitation in seeking help, or at least reviewing. Best of all, as steps beyond self-help, review with a friend. Review with a friend or a few friends who care for you, who know you, who you can trust, and say, and raise the issue. Am I overreacting, either in substance or in reviewing my reaction? Or Do I actually, am I losing balance for a short while? How do I help? Do I need really um, social support, family network, friends, and the strength of our society, much as we don't recognize, as compared to, with all respect, the American and European society is still huge. So do that. I hope that answers, Ashita. Um, no, Navya, that part. You being a good coordinator prompting me. Right. Okay, Hardika Motkil has one more, right? Would you recommend regular screening for mental health issues other than depression and anxiety? For example, if a person is not able to focus, is it due to overuse of social media or is it ADHD? Damn good question. Is it changes in mood, just hormones, or adulting as we go on learning? Thank you. Thank you for bringing it up again, Harnika. Very well. Like Navya and we had discussed in last few days while crystallizing the topics, one thing that I have really been concerned about is that society doesn't recognize systems, I dare say, don't recognize, often concerned young students don't recognize, boys or girls or even the third gender. This period of 16 or 17 to 21 to including PG, 24 or 25, is in synchrony with the most tumultuous period of human life course. So while there is this huge undue pressure, expectation, performance, deliverables, and what have you, is also the normative process of adolescence of becoming young adult as your take that in your stride as much as you can. When you say regular monitoring, I'm prompted to think of, let's say, things like alcohol or tobacco. There are simple self-screening instruments, right? And by now, with digital technology and app-based technology and even AI, that's reasonably easily accessible. So not a bad idea. Not a bad idea to have some amount of self-screening or again with friends for some of the commonest issues. But I have caution there. I have a caution there. Please recognize that like any other universe of population, medical students in a given medical college or Haryana or the country also has a spread of people with different vulnerabilities, personality profile. So it might be some of us who might actually have, by personality profile, undue excessive or pathological anxiety and concern, if not to the level of being hypochondriacal or obsessive. Okay. So know thyself or talk to friends, talk to, empathic seniors, because some of you in this idea that Radhika has suggested, which I broadly do agree with and support, but there's also a danger of some of us getting too obsessed or involved with that to a pathological extent and wasting one's energies and actually spoiling one's own health, physical and mental both. So one major thing that I would advocate is that of subgroups of people in any population, including yours, there are different methods and strategies for different people. There can't really be one strategy for all. One size fits all is eminently a wrong idea. And unfortunately, with all respect, most systems, micro or meso or macro, tend to overlook this. Individual differences and individual needs of different consumers and clients being different. A good counseling program, if your medical college has, I guess, will be taking care of that. But something like screening or regular screening can have that problem. Of course, there is this whole issue, Artika, how you realize of, uh, I took your question only first at the level of self-screening and monitoring, which is cool. But if at all, even in good faith and without good intention, a medical college or a state system where to actually start a system of regulating or monitoring, that can become a huge stress in itself and ethical problem too. You know, uh, so official mandated screening or monitoring, even if it is totally well intentioned, is a very soft, perilous ground. There will have to be at the level of organization or systems, increasing awareness, reducing stigma, creating an atmosphere of empathy, encouraging more and more people to seek help with less hesitation, And most importantly, appropriate response when a person seeks help, and no discrimination or exclusion, negative impact of seeking help or of being on medicines or on treatment. That is something that's very difficult for the systems and the social microcosm of any campus to achieve completely, again, admittedly. But that's crucial, as you'll all realize. And let's face it, I want to touch upon another issue here. If I may request you, Navya, also to note this, and we might pick it up tomorrow for long discussion. See, we psychiatrists and mental health professionals and mental health advocates of different shades, wanting to improve the social perception about persons with mental illness, person on treatment, no exclusion, no discrimination, no negativity. Oh, great. But where does it all begin? One huge group there in any society is medical doctors other than psychiatry and young medical doctors like you, who will then shape. And that's been on my mind while preparing for today and tomorrow, that besides increasing your general awareness, B, besides helping to some extent, hopefully all of you, to get a better sense of self-monitoring, as Hardik asked, my purpose is also to see that you guys, with this 2 days interaction and over time with number of other inputs, you become medical doctors and health professionals with a neutral, empathic, positive attitude and practice towards persons with mental illness. And the starting of that will be in this 4 or 5 years or 10 years. So if I might say, allow me, if there are people in the class who are on, say, even, God forbid, treatment for schizophrenia or psychosis, they are on antipsychotics, or they are mood stabilizers, or there are people who are depressed on antidepressants. There are people who are not always able to perform in group tasks as well as the others. A number of such things. Try and see if you can develop more neutral attitude, positively accepting attitude, at least non-judgment and non-discriminating, non-labeling. And I must say, that doesn't come very easy to medical doctors. Sadly, doesn't even come easy to psychiatrists themselves. And I don't mind saying this because I have said this to psychiatric societies. And unfortunately, that whole non-judgmental, empathic positioning and attitude and practice needs to be improved significantly even among psychiatrists. But certainly, huge help for your own self and for the larger social cause amongst medical doctors. And what better than such opportunities? You young medical students and resident doctors, currently in the formative stages, who are for the next 50 years going to shape the social reality. I hope that didn't become too idealistic or passionate or carrying. I didn't get carried away. Namya, you must please, you or anyone else, feel free to interject and tell me.
Okay, all right. So I think
Right?
so. We in the last
Last week,
two questions
right?
from
Oh, right. It's
Satyam
6:10.
Gaga. I'm
No,
pretty sure we haven't not many questions that we'll
I
be
know.
dealing with tomorrow in
Right.
the
So, considering an adult with a traumatic childhood, it becomes difficult for the person to handle stress even of the regular life. Who can one cope with that? Yeah, okay, right. Take care of his mental health. Yes, agreed to. Childhood trauma of, again, different shades. Having just had marital or family issues, parental discord, possibly abuse, verbal or emotional, if not physical abuse, domestic violence. We all come from the same society, and some of us might have had that. God forbid, God forbid, if the concerned persons amongst us might have had even one more step level difficulty of physical abuse or sexual abuse in one's own earlier years. Um, very delicate. But I also want to say two things there. One, the recognition that one has been traumatized is a good first step for one's own dealing with it or seeking appropriate help for it. Leaving issues significantly unresolved doesn't help, as you are, I think, hinting and raising. But let me also say this on the other end. Am I saying, or do we believe that any health professional, medical doctor, or psychologist or psychiatrist should be in perfect mental health and all balanced and all resolved? No, by no means. Please don't get that wrong. Hmm? And if at all we need to pick up, we will. The second point is that, and that's again a little delicate, nuanced viewpoint. If you'll all please try and see the finer aspect. One or the other kind of pain or trauma, having been part of one's own experience, generally can help empathize and deliver empathic services to the next person who you are a provider to better. So, negative experiences, while they can become a pulling down force, they can, on its own, and if you kind of process it and handle it well, actually can become a huge resource and enabling experience. Not easy, but as has been said long ago, I think in the Christian tradition, every tradition, one helps oneself best by helping others, especially about negative experiences or trauma or the kind of things that I think you are talking about. Bhavya Asrani has again longish question. So, being a medical student, I did before starting working on ourselves, especially for studying, as it has become common thing that before we simply compare ourselves with others and anxious, feel anxious, easily feeling that burden and pressure. How can we work? Yeah, I guess the simplest answer to that, Bhavya, would be chill. Take a chill pill. Don't perhaps see too much of an importance of you oneself or the medical doctor that you're going to be. While every medical doctor, every professional is very crucial, but if I'm getting the drift of your long comment, more a comment than question, I'm with you. Um, the pressures of academia, the pressures of parallel to academia, co-curricular services, success, how well you do, your grades, before they start working on you, yes. In other words, like NMC has begun to do, I think, a whole lot of efforts have been for last 20 or 30 years of, the relevance of behavioral social science, one's own personality development, not necessarily in the traditional, those courses of personality development kind of commercial activity, but can I use a term that I hinted at earlier? I didn't say this very well. Self-awareness. अपने आप को पहचानिए खुद या दूसरों की मदद से. None of us is perfect, far from it. Certainly at this young age, you are still, developing, like we said. But self-awareness, effort at working out as positive and good a balance as one can of my strengths and my weaknesses. But recognition and acceptance of one's own weaknesses is good for oneself as well as whatever one is trying to do for people around and the job that we are trying to now or later. Bhave, I hope that made some sense. And then Tarun Saxena is saying, so I think depression of medical students is mainly due to aggregate of factors like how to manage stress of all these things with ease. You already done the first step. Beside my slides and whatever I tried, you yourself kind of summarize what all in varying degrees for different persons. Deal with what's bothering you or me or any one of us specifically more. Don't mind seeking help. But I do want to say one more time, really, that like a whole lot of other issues where most of you might have realized, I'm really, really not comfortable with, and I am against over sensationalizing. Rates of depression, suicide behavior, much as, this report also of the NMC committee that's coming up, you'll find numbers. So many people left the course, so many people attempted suicide. While each life is important and sure, we must try everyone to do what we can. At the broad level of human understanding and policy, one has to realize, is it different from the other youth? Are they really? That data I don't see emerging, if I may say. If anyone of you knows, And I'll request, not challenge, I'll request, please look it up even next 24 hours. You guys by now must be so good at, is there really a significant difference of rates of depression, attempting suicide, whatever other behavior? This is, in fact, I'll flag this also, Navya. Uh, I do for sure, I'm sure my other colleagues do, in all major cities or even otherwise, in public meetings, this is virtual, but even in person, or on television programs or radio phone-in programs, as you will all appreciate, ever so often I get this question posed to me in different degrees of politeness. Okay. But to put it more crudely and say, you psychiatrists are half the time this society, please, you're yourself not well balanced. है ना, पागलों के डॉक्टर खुद ही थोड़े हटे हुए होते हैं, तो क्या ऐसा होता है डॉक्टर साहब? आप पे स्ट्रेस होता है? I have over time genuinely understood and formulated some responses to that be applicable to you. I hope you're getting my drift. Like I keep saying to population, I said, look, the rate at which depression or alcoholism can happen in general population can happen in a group of medical doctors and it can happen in a group of psychiatrists or say medical students compared to other youth, right? Two is the expectation that Navya reminded me of that the society places on you and you yourself. पहले समाज आपको खुदा होने का एहसास कराता है और फिर आपको परेशान करता है कि आप खुदा नहीं हो. Please understand, unknowingly, unintentionally, the society makes you feel like God, intentionally or unintentionally, and then make you feel let down by your own self. Don't let that happen. Be human. Be a normal, average human being. If you're an 18-year-old medical student with whatever vulnerabilities, whatever propensities, childhood trauma, difficulties, be that like anybody else. Sure, medical students, resident doctors, experienced doctors, and psychiatrists, no doubt, should be able to deal with it better and handle it better. Identify it, do what should be done, not respond negatively to that, whatever be the problem, alcohol, depression, schizophrenia, whatever, tobacco. But to have a problem, most often, biological or psychobiological, social, how to deal with it is a responsibility. And that we should all carry without too much pressure about how to identify, how to deal with it for oneself and help our friends around. But really, this whole thing of, being demigod and being superhuman and extraordinary expectations from young medical students, resident doctors, all of us, is a huge factor besides everything else that you have listed there. Bhavya, my friend. Okay, Tarun Saxena is in here again, sir. I think depression. No, I thought we covered that. Right? Oh, we covered that. Okay. Are we, oh wow, are we done? Strike rate 100%. Navya? Okay, cool, nice. Okay. Right. Anybody, nobody wants to switch off the video and have actually a chat, huh? Okay. If you don't, but today or tomorrow, I'll give you my Gmail for sure. I hope you noticed that on the last slide, or my phone number for WhatsApp messages. Most welcome, any one of you. I'll put that down. In fact, if some of you might not be here tomorrow or whatever other reasons, but please feel free. But I would really like it if some of you can get on here. But let me also give you, Navya has this, but I'll give you both. Email or social media messages are welcome, encouraged. Don't hesitate. Okay, you got that?
Thank you so much, sir.
Gul is a few people, a few colleagues switched on the video for a split second and then went off again. No one?
I think, sir, we'll be looking forward to switching up on our videos, interaction, panel discussion by the students.
Right. We're already at 6:20. So as you feel comfortable, Naga, you and the group. But thank you, really. Thank you and the group. This is always so stimulating and energizing. The exercise to prepare and
Yes, sir.
Okay.
All right, sir. Thank you so much, sir.
Not at all. Bye. I'll see you guys tomorrow at 6.
Bye. Yes, sir.
Bye.
Thank you so much, sir.
Bye.
Thank you, sir.
Thank you so much, everyone, for giving us the opportunity to host the session. We hope to have you again very soon. Thank you.
Thank you, Ms. Tracy.
Thank you so much, sir.